Thank you, Peter. Invite the reactor panel to join me up here, please. Thank you. So with a panel like this, the best thing the moderator can do is get out of the way. So the way we're going to do this is I'm going to ask each of our participants to take 5 minutes to introduce themselves. And if their introduction of themselves is short, they'll even have a little bit of time to make some initial comments on the report itself. So I'll leave that to you in terms of how much you want to use your time on that. Secondly, I have some questions that I want to ask the members of the panel. They'll be short. And then we'll ask you to react to our reactors. So that will be the game plan for about the next little over an hour. So Dave, why don't we start with you, an introduction and an initial reaction.
Great, thanks very much. I'll dive right in. My name is Dave Chokshi. I work at New York City Health and Hospitals, where I serve as the Chief Population Health Officer, and I'm also a primary care physician. I get to practice at Bellevue Hospital. By way of provenance, I'll start by saying a little bit about our system. Health and Hospitals is the public healthcare system for New York City. We take care of about 1.2 million patients a year. Functionally, we serve the poor and the working class of New York City. About a third of our patients are uninsured. That's our post-ACA number. The vast majority of the rest of our patients are on Medicaid, either a Medicaid managed care plan or Medicaid fee-for-service. And less than 15% of our patients are actually covered by Medicare or commercial insurance. So just to give a sense that we have kind of the reverse payer mix of many other nonprofit health systems. I'll say a little bit about our approach to high-need patients. And our journey began about 3 years ago. I divide it in my mind at least into 3 pretty discrete phases. The first was thinking about superutilizers. The second was thinking a little bit more about predicting future utilization and using that as a way to mark high need. And then the third phase, which we're within right now, is really kind of getting to the so what, to operationalizing, what we mean when we say we want to take care of high-risk patients. So I'll say a little bit more about each of those phases to chart our journey over the last few years, and then if I have time, I'll make some comments on the report as well. So where we started about 3 years ago, as I mentioned, really inspired by Jeff Brenner and many others in focusing on superutilizers, was to just start with our data. And what we found, as with many other health systems, was that we had hundreds of patients who came to our emergency rooms over 50 times in a 12-month period, or were admitted to the hospital over 20 times in a 12-month period. We found that there were dozens of patients across our system who actually spent more time in the hospital during the course of a year as opposed to at home or in the community. And that was very focusing for us. That gave us a burning platform, to think about how to take care of that set of patients differently. About 18 months ago, we started to shift our mindset from a purely retrospective look at high utilization to instead trying to be more prospective about predicting that utilization and getting at markers of risk for future acute care utilization rather than solely looking at past utilization. I'll say a couple of things about our approach during that second phase. The first is we came from the starting point that we needed to approach this problem in a payer-agnostic way. So whereas it can be tempting and sometimes easier to look at specific payer populations, and for us, for example, we're part of a Medicare ACO, we thought that the most comprehensive way to approach the problem was to do it payer agnostic. The second was we found it was very useful to look at a composite outcome of predicted future utilization of greater than 10 days in the hospital, either an ER visit or an inpatient visit. And then the third component of our high-risk approach was really to try to incorporate the social determinants of health from the ground floor. So we did this in relatively simple ways, looking at things like the number of zip code changes that we could discern, that our patients had, as well as payer churn, moving on and off different insurance plans, or for many of our uninsured patients, having insurance for some period and then coming off of it. The other thing that I'll just convey in terms of what we learned during that second phase was that less than 25% of our patients, of our high-risk patients, were actually engaged in primary care. So this completely shifts your frame in terms of thinking about how to care for those patients. And then the second thing, which echoes the report, is that our high-risk patients changed both over time and for our system, which is very large. We're 11 hospitals, over 80 community clinics. We encompass 5 nursing homes as well. Our high-risk patients actually changed their care-seeking locations also. So that also changes how we think about a holistic model across our entire system. So that gives you a little bit of a flavor of how we approached high-risk patients. What I'll do just very quickly is offer some initial reactions, upon my reading of the report. The first thing to say is just to echo the congratulations. To me, it's a really remarkable collaboration that was able to come together to put together this report, something that's pretty rare in health policy. I really congratulate the people who organized it. I think a couple of things that really jumped to the surface for me on my reading was, number one, just the scoping of the problem. The fact that we can now say about 12 million patients are high-need patients, I think is very clarifying in sort of a call to arms about what needs to be done to take better care of those patients. And the analogy in my mind is another IOM report, To Err is Human, where that statistic of 98,000 patients who suffer from medical errors each year was something that was surprising to many and galvanizing because of that. From my perspective, in the delivery system, the two most useful components of the report were the taxonomy, as well as the elements of tying care models to the taxonomy. I really appreciate the humility that it's couched in. We are not going to take that starter taxonomy off of the shelf and implement it within our system, but it's a very useful check for us to make sure that the way that we're organizing care management and our approach doesn't leave any gaps with respect to the groups of patients that we're trying to serve. So I'll leave it there and pass the baton.